did you guys look at these yesterday at all? Yeah. Okay, so meet your Goni. Hello, Goni. Different part. Your big circle thing is called our axis. Then you have a movable arm, you have a stationary arm. For hip flexion, Kay has been, Dr. Rubio, sorry, has been nice enough to go in some shorts because it's easier to see some landmarks. So hip flexion, range of motion is going to be measured in a supine position. So have your client laying on their back. Right. The mat. No. Thank you. Remember, don't hurt your back. So you have high low tables.
Is it okay if I come scoot
So
really close
hip
to you?
flexion,
Yeah.
that's what that's going to look like. You want to put your axis of your goniometer
Thank you.
on the greater trochanter. And if you can't find the greater trochanter of somebody, what you can do is you can take their little ankle and you can move it around. That's exactly how you can feel the greater trochanter. So if you're having a hard time, and that's okay, you just take their leg, move it around, you can feel that bony part. So the axis is going to be placed right on that greater trochanter of their femur. The stationary arm is going to be parallel to the mid-axillary of the trunk, mid-axillary line of the trunk. The movable arm is going to be placed parallel to the mid-axis of the femur, pointing towards the lateral epicondyle, okay? So then can you bring your knee to your chest? The reason why I move my Goni, some people like to follow along. If you do that, your axis is going to move. So what I would recommend is lining up, then taking your goniometer off, have them do the movement, and then place your goniometer back on, okay? All right, is that all you got? Mm-hmm. Are you sure? Yeah. Okay, 115. All right, relax. Normal range for hip flexion is 0 to 120. So she was 0 to 115. That's pretty good. That's normal, right? How'd that build? Huh? Okay. So you always want to ask them if they can go anymore, okay? But when you ask if they can go anymore, do that again. Make sure clients will really want to impress you that they're not doing any kind of substitution. So they're not like, yes, I can do it. You know what I mean? Make sure their back is flat on the table. They're only doing hip flexion. Make sure their knee is bent, because imagine, bring your leg up to the ceiling. Oh, exactly. Pretend you don't. Okay. There you go. Okay. So the hamstrings need to be on slack when you're doing hip flexion. Okay? Go ahead and turn on your stomach. So we're going to do hip flexion and hip extension, then I'll have you guys measure, okay? All right. So the big thing for this is if we were measuring the same side, if she flipped over, I'd be measuring the other side, right? So just for this purposes, I'm going to be just, for simplifying, I'm measuring here, but if you're out in the clinic, just make sure this is the same side that you just measured, okay? Hip extension. This one you want the knee not bent. Can you bring your leg to the ceiling? That's hip extension. Same landmarks, okay? Lay back down, relax. All right, so here's your greater trochanter. Find that by doing this. Having a hard time. Placed over the greater trochanter is your axis. Your stationary arm is going to be pointed towards the mid-axillary line of the trunk. If you guys want, you can come over here and look. I'm having a hard time. And then the movable arm is, again, pointed towards the mid-axillary line of the femur, pointing towards the lateral epicondyle. Okay, can you bring your leg up, please? Is that all you got? Mm-hmm. Are you sure? Okay, relax. Yeah, 29 degrees. Normal is 0 to 30. That's good, right? You want to get to the closest of the end range, meaning that they took all these norms of all these people and found that 0 to 30 is normal. So, say you got 15 on one side and 30 on the other. There's probably an issue, right? An issue being muscle strength, muscle weakness, and that's why we most of the time measure both sides, because we're trying to figure out, does this look okay? Are they having problems getting dressed because they can't, bring their leg up, or does that make sense? So when I say range, I don't want you to be like, oh, 15 degrees of hip extension, so that's within normal limits. Well, really, that's half of what the norms are, right? So then we kind of want to look, you know, is the other side 15? And sometimes that's okay. So what you're looking for is symmetry. So if Dr. Rubio has 29 degrees on this side, 29 degrees on the other side, that's okay. But if they've got 10 or 15 and then 30 on the other side, then you kind of want to, all right, let's dive into this. Let's figure out what's going on. All right? Make sense? Okay, let's go practice. With me with your Goni, because we're going by the red numbers on your Goni. It's different, okay? So, hip abduction. Access goes over your ASIS of the test side. So I'm going to be testing. So I'm going to find her ASISs. Very easy. Okay. Access goes over that. Your stationary arm needs to be placed literally across the line to the other ASIS. Okay. Your movable arm is following along to the midpoint of the patella, okay? All right? So, can you bring your leg out, please? Actually, can you scoot over, please? So if I had her leg move out, she would have fallen off the table. Don't let your client fall off the table, okay? All right, go ahead. And bring your leg out. Ooh, goodness gracious. Is that all you got? Oh. Okay. So I have 50 degrees. 45 is normal. So she's plenty. She's good, right? Now adduction, just remember, you're adding to the body. You have to move the other leg out of the way, okay? Because we're coming now towards the body. So if you left her leg here, she'd be like, I can't go anywhere. Make sure you move this leg out of the way, okay? Same thing. ASIS, midpoint of the patella. Can you bring your leg over? Is that all you got? Mm-hmm. Good. I've got, are you sure? Yeah. Don't make me laugh. I got 15. Okay, and that one is 15. I'm trying to think of the range. I think it's 20. I have to look. Okay. It's smaller than abduction. Or maybe it's the same. Oh no, I'll look through that. But big point to remember is that abduction, leg goes out. Adduction, opposite leg needs to move out of the way for the test leg to go over. Okay?
The range is 0 to 30.
Thanks, Melanie.
What are the possible substitutions there?
Yeah, what do you think your client would try to do?
Moving their hip up.
Moving the hip up, yeah,
Trunk.
moving the head.
Lots of trunk.
Or if I turn my leg out this way,
Then there's
more abduction. Okay, and if I turn my foot inwards, that's more abduction.
So foot needs to be just up,
Pointing up.
pointing up, okay? Yes, ma'am.
When you're doing the adduction, how far do you move the opposite leg as far away as you can without them kind of rotating or moving their trunk at all? Is
Yeah, and I
that
would probably get out of the way at that point.
okay?
So can you come closer to me? So probably easier
I'm
sorry.
Okay.
to measure it this way. It's 30 degrees, so it's not like she's gonna be like, you know what I'm saying?
Right.
So 30 degrees is the norm.
What about like for active and passive for this? Like wouldn't active be a lot further? Is it, because if you manually moved it, wouldn't it be able to move a lot further?
So typically passive range of motion can be more than active range of motion.
How do you, like, can you use
So
either
in this
or?
class, we always use active range of motion. In your further classes down the road, we will be doing more passive range of motion stuff. Passive is the therapist doing it.
Oh, okay, I
Active
think I
is
mixed the two up. Okay.
the
Yeah.
client doing it. Move your leg over. Yes. Does that make sense? Did I answer that or no?
Yeah.
So for like, typically, like if you're measuring shoulder flexion and your client does this, you probably could get passively more because it's easier for you to move versus the client if it's a weakness issue and there's no contraindications and stuff. But for kinesiology, we only do active range of motion. Okay? All right. Let's practice. an external rotation, okay? Position is your client's going to be seated. What's different, and maybe Dr. Sarah could get us some towels. I think they're in that room. Why do you think I need to put a towel underneath her leg?
So it doesn't move.
So it doesn't move?
Yeah.
We want it to move. Right.
That way you can go back further without the chair blocking.
I'm saying friction is gonna hurt, right?
So she can slide.
So motion is unlimited?
Okay. Ish. So we have a nice line. Okay? So if she's way down here, we're not going to be starting at a good line, right? Whereas here, that's nice, nice and good. 90, 90. 90, 90. Okay? Hip internal and external is kind of funny because you're not looking at what this does, right? You're looking at what the hip's doing, okay? So what is this? I'm sorry, okay? I'm throwing out like a little ragdoll. Right? What movement's this? Right. And then external rotation, right? Okay, so when you're in the practical and you get that, like, I would write on my paper, foot goes such and such way so you don't get mixed up, okay? Because you're always looking at what the hip is doing, okay? All right, so goniometer access is going to be the midpoint of the patella, okay? Your stationary arm is going to be perpendicular to the floor. And then your movable arm is going to be falling along the anterior line of the tibia, okay? All right, so we know that she's starting at 0, okay? Can you move your foot out, please? Is that all you got? You sure? Okay, so I've got 36 degrees. Normal is 45. All right, same thing. Can you bring your leg in? Is that all you got? 26. Okay. 45. Both 45 and 45. So she's a little bit less, so what I would probably do is measure this side. It's going to be okay. Like if you get a client or even in the practical and you're like freaking out because your goniometer says 26 and you know that the normal range is 45, that's okay. I want you guys to put what your client got. Just note that, okay, well normal range is 0 to 45, so maybe there's some tightness issues that we can work on, okay? Don't try to move your goni to make sure you get 45, okay? We want to put what your client gets. Yes, sir?
Why is 0 considered normal? Wouldn't that be no movement?
It's not 0, it's just how you document. You want to document the range so that your client started at 0 and they ended at 26 or whatever she did. Because like I was saying before, some of your clients aren't going to start at 0. And so if you think about it, so say Dr. Rubio started at 10 degrees of internal rotation and then she went to 26. That's not going to be 26 degrees of movement, right? That's going to be 26 minus 10, which is only 16 degrees of movement. That's why you always want to document where you start and where you end. Dr. Saradic, Dr. Rubio, Dr. Mariani, want to add anything to that? No?
And this is where, like what I said yesterday, what the occupational profile will give you guys. So I run a lot and I don't stretch. I'm a bad patient. I'm a bad example. So I do have a lot of muscle imbalance, especially in my knee and in my ankle. Okay, so I don't have a lot of.
So I bet you if I measured this side, she probably have very similar measurements to her other side, which is okay because that's symmetrical to her. But she probably could still work on some stretching and get a little bit more motion, right? But what you're worried about is if you have measurements over here that are way off from here, then you definitely want to see what's going on there too. Yes, ma'am?
Did you say that we're using the 180 or 360 for this one, like the red or the black?
Using the black numbers. You're starting at 0. You're looking where the black numbers are. So where the leg moves is what you're, the movement. Does that make sense?
I remember Dr. Rubio said yesterday, you won't ever be using the red numbers on the inside, that's 360 degrees. We don't do that. If your goniometer, can I borrow your goniometer? If your goniometer is here, or if it's here, you're reading the black numbers. If it's at a 90-degree angle, when you start, you're reading the red numbers on the outside for this particular goniometer, okay?
And really, only thing you need to worry about is so for ab and ad so far, that's when you use the red numbers, but not the very inside, the outside red numbers, because you started at that 90-degree angle.
Yeah.
Okay?
Lisa has a question.
Yes, Lisa?
I remember yesterday you told us as we go about this to kind of talk to our client about what we're finding as we go. Is there like an appropriate way to, if they aren't quite meeting the normal range of motion, or if one side is a lot less than the other, is it inappropriate to say that you're lacking range of motion, or how do you?
It's definitely not inappropriate, and it'll be part of your practical where you have to do your conclusion with your client. So, okay, Lisa, today I measured internal and external rotation of the hip. I got these measurements. Normal range is typically this, so it looks like we could schedule some more visits and work on this. So you're always going to be talking to your client at the end and telling them, this is what I got, this is normal for this purposes. And then as you get along in your studies, you'll do a little bit more in-depth stuff. But here, it's not like you take your measurement and you're like, okay, bye, I'll see you later. Like, you want to make sure, okay, like today we did some measurements on your hip, your knee, and your ankle. This is the measurements I got. This is what normal range of motion is, or muscle strength. And then if they're normal, they're normal. If they're not, then you say, okay, let's work on this stuff. Is that all right? Does that sound good? Yes.
So if you were obviously doing it with the patient, you're looking at both, you're gonna be measuring both, right? Not just one.
Typically you're measuring both sides all the time, and typically you're going to be doing what we call like a gross screen. We'll get into all that stuff because you're not going to have time to take every single little measurement. Once you see them do a screen, like if I was like, hey, can you lift your leg to the ceiling, and you're looking at hip flexion and I see that she probably can't, then I would be like, okay, let's focus on, I'm going to measure this. Does that make sense? But we want you to know when you go out and practice how you measure these movements. But when you're out, you're typically going to do in your head like a gross screen, and then focus on the areas that you think you really need to measure. Because typically you're going to say range of motion is within functional limits on the left side, not on the right side, or you know what I mean? Does that make sense? And does anybody in here are we finding some not normal range of motion? It's okay, it's no big deal. Yes.
If the range of motion is normal on one side, do you have to take the measurement on the other side, or do you just measure for symmetry if you're finding like abnormal range of motion on one side?
Well, you probably wouldn't know unless you measured, right? If you're screening, you could know. Does that make sense? Are you asking like in a practical purpose or like in real life?
I was just saying, so say this is normal 0 to 45 and it's 45, or what if it's 20, then you would want to measure over here to make sure that it's kind of similar. But if it is normal, like 45, do you always have to do both sides, or do you just?
Well, typically you're probably in real life going to test the unaffected side first, because that's going to be your baseline. Does that make sense? So say you hurt that other leg, you want to probably always measure both sides, unless you're doing a screen and you can see that there's probably no issues going on. Did I answer that?
Yes.
You sure? Okay.
But for the practical, you just need to measure one
Just
side.
do one side?
Just one side for the practical.
Thank you.
In the clinic, I always measure both sides.
Yeah.
Now with the fingers, if they can make a full fist, I will just put patient able to make a full fist on the right hand. I don't necessarily, because that's a lot of measurements.
Exactly. Like you're not going to have time to do every single one on the whole body, but you're able to hone in by doing screens and all that stuff. Yes.
If you get a measurement that's abnormal, can you go ahead and be like, hey, can we go back to starting position and try it again?
Of course, yeah.
Okay.
Like, this is not, it's okay, like, if you guys feel like, if I'm getting 60 degrees and I know the norm is 45, it's okay to go back and do it again. Like, hey, let me do that again. And I will say you have 10 minutes to do your practical, so you need to move at a pretty specific, efficient time, but you'll have plenty of time. And if you feel like you got a wrong measurement, I would go back and do it again. And that's okay if it's in the middle, the end, whatever. As long as you tell me, hey, I'm done. If you want to go back and do some stuff, it's okay. Yeah. Yep. Yes.
How many measurements do you typically do, like in practical?
Well, typically 3 or 4.
In the practical exam, just one movement per range of motion, and then one muscle group from manual muscle test.
Well, yeah. Okay. We'll go with that.
Okay.
I mean, we're doing hip, knee, and ankle, so you could get a hip, knee, or ankle.
Right, but we'll only be asked to do.
Maybe.
So what you, for the practical, you're gonna come in, you're gonna do your
Spill, we're gonna, before you even start your spill, we're gonna say, you're going to measure hip flexion, range of motion, and ankle dorsiflexion, or, well, in this one, it's gonna be a little bit different, but this motion for manual muscle testing. So you're gonna have one range of motion, one manual muscle testing. Okay? You're gonna know that before you start. You're gonna have about 5 minutes. Is that what we do? Like 5 minutes?
5 minutes to prepare, yes.
5 minutes to prepare. So when you come in, we're gonna say, this is what you're doing, and you get to prepare.
Like, you're not gonna walk in and I'm gonna say, all right, let's go to it. Like, you're gonna have time to put your stuff down, write your stuff out, you're gonna get a prompt, what you need to do, and then after 5 minutes, timer's gonna go off and then you start.
Great.
Do we do it in front of all 4 of you?
No. There's gonna be 4
You'll have,
groups.
you'll have one of us.
Okay.
Yeah.
Yeah.
And each practical, you're going to have a different professor.
I wanted an addendum to my answer. So we're doing lower X this institute. For occupational therapy, we do gross assessment of the lower X. Okay, so it's the manual muscle test will be different, might be different this time around, but when we go to the upper extremity where we have to really assess each muscle group, it's going to be one range of motion and one muscle group. But lower X, it'll be a bit different. A little bit.
We'll do mock practicals, you guys will have, you'll know what to expect. I
Yeah,
promise.
tomorrow, all day, you're gonna be able to practice this.
That doesn't mean you don't practice at home, okay? Promise me
Exactly.
You'll practice at home.
And then next institute on Friday, you'll have
Yeah.
your exam in the morning, and then you'll have about 2 hours to practice in an open lab to practice and ask questions. But the more you do this, the more repetition you do with your spiel, the more you get somebody and different people and doing different landmarks, you're going to become more and more comfortable with it. The more you play with your goniometer. So practice, 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 okay?
Did we get towels? If not, we can
Yes.
just use pants.
So I just wanted to add something about the question why we have to put a towel underneath. So yeah, it's correct. The hip has to be a 90, the knee has to be a 90. What plane of motion is this? Internal, external rotation is while the person is seated. What plane is this? Frontal. What axis? Sagittal. So if my knee is down here, it's not going to be perpendicular to my plane of movement. I want it 90 degrees, so with that it's perpendicular. Okay? But if we do internal, external rotation in standing, what plane is this? Transverse. Very good. This way. Okay? All right.
All right, let's measure. All right. Make sure if you get knee, you're down here and you're not up here. Because some students, you know, you're nervous, you get confused. But what I want to say for here is it's super important why you don't try to follow the range on this one, especially because could you bring your foot to your bottom, please? You try to follow, you're going to be like way up here. And sometimes it's really hard to find that lateral epicondyle, which is what your axis goes on, because there are a lot of bony parts in the knee. So make sure you know how to find the lateral epicondyle, which is right here. Wish we had the marker. I don't have a marker. That's all right. So, like I said, axis is the lateral epicondyle of the femur. She's starting at 0. Your stationary arm is falling on the midline of the femur, pointing towards the greater trochanter. Your movable arm is pointed towards, it's falling along the fibia, pointing towards the lateral malleolus. Okay? So can you bring your knee to your bottom, please? Is that all you got? Are you sure? I have 134 degrees. The range is 0 to 135. Yes. All right, so that's knee flexion. Okay, so not up here, you're at the knee, lateral epicondyle, lateral malleolus, greater trochanter for points of reference. I would not try to follow with your going. I would let them do the movement and then I would realign. we are. Okay. So, you know what I messed up? This is what we should have towel. Right? This is wet. Someone's towel's wet. Sorry.
Sweaty, nervous.
Look at the wet towel on your leg. Don't take that. You just...
We gotta have jokes in it too.
Alright, so... Alright. I don't like it. So, towel needs to be, just like internal and external rotation, I'm sorry, the towel needs to be underneath, right under above the knee, under the thigh, okay? Bring your leg up. Under. I think it's just for extension.
It's for extension.
Don't listen to that. Put your leg down. So, sorry, for knee extension, you need to have the towel under your leg, and that's important because for this one, we're looking more to see if we have hyperextension. That's what we call. So 0 is normal. So some people have no hyperextension, and that is okay. But some people can have as much as 10 degrees of hyperextension, okay? So I'm gonna line up just like I did for knee flexion. All right, and the kind of the phrase you want to give your client is, can you straighten your leg? Is that what you
Yeah.
1 degree of hyperextension. Totally okay. I think I have 0, so make it funny. Okay, so knee flexion, no towel. Knee extension, towel. And then if anybody has like a huge amount of hyperextension, let us know and we'll come all and look at you and tell you how weird you are. Hit it. So, yeah. So, you guys know, like, little children or even gymnasts, they have a ton of hyperextension in their elbow. It's just like that with the knee. I don't. But my son is like, it's crazy how hyperextension. Ew, like that.
Oh, ew.
That's gross.
Whoa.
Do it again. Lisa, please. Do it again. Perfect. All right. So that's what we're looking at for the knee, okay? Let's see. Oh yeah, look at Jordan. You can even see it. Come on around here. Wow. Jordan. Relax for me.
We know who the strange people are now.
So if you get Jordan in the practical, make sure you know that you're gonna have some hyperextension. All right, go ahead and. Oh my. What?
Wow. Wow.
Relax, relax. Yeah, you got about 9-10 degrees.
Woo!
Okay. Alright, so what's important here is that the foot is going to be off the table. We should have some sort of bolster here because what we're trying to do is put the gastroc on slack because the gastroc is a 2-joint muscle, correct? Alright, we're going to be measuring ankle dorsiflexion and plantar flexion, okay? Alright, so.
For those of you like right here, can you kind of slide up there?
You don't need to move forward anymore. You have
So your access for this movement is going to be just inferior to the lateral malleolus, which is very easy to find. And your stationary arm is going to follow the longitudinal axis of the fibula, pointing towards the greater trochanter. And then your movable arm is going to be parallel to the sole of the foot. Good. And what I like to, actually, come off a little bit more. What I like to do for this one is that I kind of start them at 0. So so their natural position is plantar flexion. So I like to start them right at 0. Okay. All right. So can you bring your toes to your nose? 10. That's okay. Is that all you got?
Mm-hmm.
Okay. So dorsiflexion has a lot less than plantar flexion. Normal for dorsiflexion is 20 degrees. So plantar flexion is the same thing, just bring your toes to the floor. And you're not following the toes as your reference point, you're just wanting to be parallel to the sole of the foot, okay? So you're not like, oh, whoa, way down here. You're just making sure that your landmarks are followed up and you're following parallel. So you've got 52. 0 to 50 is normal. Okay, so that's good. Question?
So some she points her toes, it's kind of curved at the bottom. You follow the plane of like the heel.
Yeah.
Kind of? Okay.
Perfect. So you're just inferior to the lateral malleolus. Stationary arm is parallel to the longitudinal axis of the fibula, pointing towards the greater trochanter. Your movable arm is parallel to the sole of the foot. Okay? And then make sure you try your best to have at least try to put the gastroc on slack and having the ankle hanging off the table, because if you don't, you're not going to get an accurate measurement. Okay?
So, and for your PowerPoint pictures, you could take a pillow. You want to?
Yeah. Yeah. I would probably try to do your pictures here for at least this one, just because you don't have a bolster probably at home, and we have at least something we can try with these tables as well. And we have two, Melanie. I'm sorry, Dr. Mariani. We've got the other.
And what's the normal range for flexion, for plantar flexion?
Plantar flexion is 50 degrees.
Thank you.
That's better.
Your book does say to place the knee in 20 to 30 degrees of knee flexion to put the gastroc in slack.
You guys hear that? Can you say that louder, Dr. Rubio?
Alright, so place the knee in 20 to 30 degrees of flexion to put your gastroc in slack. That will give that will allow your ankle to move within its full range of motion in dorsal and plantar flexion.
Okay, so nose to your toes, toes towards the floor. Okay? Alright, cool. Let's go. And the smaller goni, okay, for this one.